So let me move on and introduce the panel, if I may. Hopefully I didn't go on. No, good time. We have three wonderful ally organizations represented: Iora Health, Partners in Care Foundation in California, and Tivity Health. They've been wonderful partners to us in talking with us about what their needs are, what they do. They're real innovators, and I think we have some exciting, we'll hear some exciting comments. I'll ask each of them to talk a bit about the work that they do, and then I'll have questions if you don't, but we'll turn it over to questions. So first is Dr. Neal Patel, who's Senior Vice President and Medical Director of the Northeast and Phoenix regions at Iora Health. I visited with Iora Health in Boston at one point, and we've been very, very good allies. He's been with Iora since its inception in 2010, so one of the founders, and he has also worked across the world. He has worked from Ecuador to India, so he's had a very broad range of experiences. He is a family physician, trained at Boston University and received his MD at Rutgers, New Jersey Medical School. June Simmons I feel like I was a friend actually in California. She's CEO of Partners in Care Foundation. She founded the organization in 1997 and has led its role in improving care for those with chronic conditions ever since. In 2018, she was inducted into the California Social Work Hall of Distinction. She's authored, co-authored, and contributed to more than 14 professional publications. And I know she'll have interesting things to talk to us about. And David Bartley, who is Chief Product and Innovation Officer for Tivity Health, the leading provider of fitness, nutrition, and social engagement solutions. I know the company has grown some. I'm probably best known for silver sneakers in the MA space. Early on, understood how important fitness and exercise was tailored to seniors over 65. So really been leaders, and I know taking on some additional roles. So he's had other leadership positions in healthcare, including as Director of Innovation Center at Humana. He holds an MBA from Vanderbilt University. So to each of you, tell us a bit about your mission. Tell us about how you've been addressing COVID. Maybe if a chance, some lessons learned, but we'll get into that and look forward to hearing from you. So Dr. Patel, can we start with you?
Yeah, sure. Thank you. So first of all, thank you for having me. Thank you for all of you who are interested in spending time to learn from us and each other. I'm grateful to be on this group. So we at Iora Health are a primary care company. We take care of seniors, mostly on Medicare. We mostly partner with Medicare Advantage plans. And we are absolutely a mission-driven organization. We talk about our mission to restore humanity to healthcare. So that's sort of one thing I'm very proud of, as we've, like many of you, worked hard to pivot and adapt to treating our communities during COVID, is that we've been able to sort of lean into our mission rather than adjust it or change it, because absolutely it's a time for us as healthcare providers, but really as a society to, restore humanity in the way we treat each other, in the way we respond to crises, and we've found a lot of guidance actually in our own mission. I can share some thoughts, Congresswoman, about how being a value-based company and being a Medicare Advantage based company has helped us to make some of those changes, if that would be helpful.
Yeah.
Yeah, great. So, as you guys know, with companies like us, and you mentioned some of our great colleagues at Oak and Chen and many others who are practicing value-based care and practicing sort of what I would call pure value-based care. We really aren't, we're at a distinct advantage relative to some of my colleagues that we aren't trying to adjust or adapt a larger organization, a fee-for-service-based organization to value. We're built from scratch around value. And so that's helped us in a lot of ways as we pivoted in early March. I'll say right away, in order to restore humanity, in order to deliver those resources to our patients to restore humanity in their lives, we need to afford it, and that money comes from value, right? So we know when patients are well cared for and taking care of themselves, feeling engaged and really at the lead of their own care, that they do well. They're healthier, they're happier, they make good decisions, and their total cost of care becomes more rational. And we can use that savings to sort of pay for all the services they appreciate, the engagement, the health coaches, the smaller panel sizes, the extra time, that sort of it becomes a reinvestment in a circular way so that better care unlocks more value, which leads to better care. Talking about COVID, like many of our colleagues, as soon as the crisis really hit us, I shouldn't say it hit the world, hit the world earlier. We were caught off guard like many of our colleagues. When it really hit us, the first thing we did was get on the phone and call all of our patients. And you know, what's in retrospect, what was great about that is that we didn't have to think for 1 second about reimbursement or loss of revenue when we had care teams doing that work instead of other important work. It was very natural. The other reason why it's very natural is being a value-based company and being a very relationship-focused company. We already had a culture and a staff, for example, our health coaches were, community health workers, lay people, who were already attuned to relationships and responsibility for panels of patients. So when we said, hey, everybody quick, call all of your patients and check in on them, it was very natural. We weren't asking people who, prior to the crisis, were being held accountable for performance of a particular activity serially over patients they didn't know quite well. They were already being held accountable for the health of their panel, and so it was very natural for them to pick up the phone and call. In addition, I'll say that, it was I think it was like, within a week, we rolled out nationally a process and a script for calling patients. We tested it within 24 hours, scaled it in 48, and we're doing it everywhere like the following Monday. And, I'm proud of that, but I'll tell you why we were able to do that is because we have care teams and doctors and health coaches who already had been engaged in process improvement, who already were engaged with our mission to figure out how to practice value-based care for seniors, and already had the humility to know that this playbook hadn't been written. So when the COVID crisis offered us an opportunity to write a new chapter of our playbook, we had a staff and a team that was already quite accustomed to doing that, accustomed to change and accustomed to, frankly, failure and learning and cycling again. So we were able to respond quite quickly.
Fantastic. Yeah. Well, maybe we move on, and then we'll come back to where we go from here, actually. But it's really, let me get myself on video too. Okay, well that was great. So we'll talk more. So June Simmons, June, would you just jump right in? Would be great.
Sure, thanks. I appreciate the opportunity to be here and admire the work you're doing. Partners in Care Foundation is what we call a community-based organization. It's in Los Angeles, and we were founded to really try to integrate what now has become a watchword, social determinants of health, some of these kinds of factors that in the old days when we began didn't really have a name. But now I think everybody's realizing that the way people utilize the care they receive, how they actually live, the resources they have, the knowledge and skill for self-care are very important, and their social connectedness and safe environment. So we are used to identifying, testing evidence-based models of care and then helping scale them so that there are resources available for healthcare payers and providers, physicians, hospitals, health plans to partner with an organized community delivery system. Didn't used to be, it just had to say, well, if I want a meal, I'll call this place. If I want transportation, I'll call that place. If I want case management, I'll call that place. And so we've tried to build integrated delivery systems on the community side and then link them to healthcare so that we could really have an integrated whole person system that draws on the real expertise that is also in the community. So a lot of what we do is assist people in learning how to manage their chronic conditions or their health challenges. And we did that all in person and utilizing evidence-based health self-management programs around falls prevention, managing diabetes or managing hypertension. And with COVID, we immediately had to convert to virtual programs. So we've been doing a lot as as Dr. Patel was noting, around telephonic, around devices, and also around interesting new innovations. A lot of people don't have devices and can't understand them, but they all have a TV. So we're working now with a two-way TV that's live, real, can create group experiences, can create individual interactions, and participate in a range of other formal activities. Because staying at home, wow, you got to fill the time and you got to stay connected. You know, loneliness and social isolation is really a serious factor. And then the other thing that we do is social care coordination. We do immediate post-acute to reduce readmissions, help stabilize people when they come out of nursing homes and hospitals, but also what we call long-term services and support. So real alternatives to nursing homes, helping people live in the community. So people staying at home safely, we already did that. You know, we have a few thousand people that we follow for long periods of time. Still, we can't go to the home now like we did. And so this whole issue of staying connected, of loneliness, of isolation as really big risks, depression, anxiety, we're seeing a lot of these kinds of considerations that people are getting in trouble around beyond getting food to them. They need a way to be a person in the eyes of others and to stay connected. And so we've done a lot of things. There's training programs now that are helping volunteers who used to deliver meals. Now they're not delivering meals, but they can make calls. They can become a buddy by phone. So there are those kinds of natural connections that are getting built where helping people connect with each other. They can call each other if we can serve as a broker, if you will. And we can provide meaningful and responsible activities, but we can also, even if we don't typically go in the home like we usually would for care coordination, we can do porch drop-offs. We can take food and get in eyesight of each other and bring something. And then we have what we call caring calls. Usually if we're doing long-term case management, we're talking to people periodically. Now we talk to them often, and we're seeing what are they losing besides the obvious things, because maybe their neighbor used to do their grocery shopping and now the neighbor isn't grocery shopping, doesn't want to come and see them and bring it to them. Maybe because most of these people are on Medicaid, maybe they're running out of things that really, like if you don't have soap or shampoo or a way to deal with even cleaning goods for your home, it's very frustrating. People have simple little things that nobody pays for that worry them, because there they are by themselves, not enough to do. And so we've raised special needs funds to try to identify the things that are really important to people that seem like they might not be meaningful, but that really let them know someone knows who they are, someone knows what they need, someone's going to get it to them, and they're going to be able to have control over getting the essentials that they need to have because they can communicate with someone and get a result. So we think these are really important supplements. So then of course we could have a whole other conversation about trying to work with Medicare Advantage and trying to add the supplemental benefits, which are proliferating, but that'll be maybe a later discussion. So these are some of the things that we're finding are emerging needs as people are staying home longer than they thought by themselves and trying to keep their spirits up so that their health stays up. So there you go, some thoughts.
Thank you, that's great. And we'll get to some of those other, what else do we need to be doing? What are lessons learned for later? David, Bartley, tell us a little bit more about what you've been up to.
Sure. Absolutely. So I appreciate the time and the opportunity to share. So Tivity health more broadly, our mission is empowering adults to achieve their best lives through fitness, nutrition, and social connection. We've talked a lot about social isolation and loneliness today already. But within the Medicare Advantage space, the brand within Tivity most well known is Silver Sneakers. And Congresswoman Schwartz, you mentioned it earlier, is most people think of Silver Sneakers as the gym benefit, and that Medicare Advantage members have the ability to go to a gym. But if you look back over our nearly 30-year history, it started with that premise of exercise curriculum tailored specifically to adults. And the gyms became the first conduit through which we could offer that, and has become they're very vital partners of ours in delivering that curriculum that ultimately builds community. But when the pandemic hits, when the core of your business is seniors getting together at a gym, you can imagine that our volume significantly dropped. Unfortunately, we had been investing sometime over the past 18, 24 months, we've been moving to embrace the digital reality of this and taking a lot of the classes that are offered in gyms, making them available on demand within the Silver Sneakers site. And it had steady adoption. Obviously, when COVID hit, we saw the utilization of that nearly double. But for us, we knew that it wasn't enough. So I think within the first few weeks of things really shutting down, we immediately pivoted over to having our national trainers, our instructors, take the classes that are offered typically in the gym. And the first thing we did was just make it available on Facebook. And so we had Facebook Live events that had a tremendous following, and they took off really quickly, a few thousand in the first couple while people were hearing about them. But I think at one point, some of our live Silver Sneakers classes on Facebook had nearly 60,000 live attendees at any given time. So we knew we were tapping into something of people needing this routine. And what we knew from prior to COVID is that the fitness classes were the reason that people would go to a gym and take a Silver Sneakers class, that fitness was the excuse. But what we find is that the connections they make, that social connection of their classmates, really is what drives the stickiness. And so when COVID hit, people were really missing that connection. They were really missing that routine. And our quick move to Facebook showed us that people needed this live interaction. So the next thing that we did was made live classes available within the Silver Sneakers site. So for Silver Sneakers members, opened up additional options for them to register. And I think at this point, we've got 4 or 5 classes a day across a variety of topics, not just fitness. And we're averaging upwards of 300 or so attendees per class. I think some classes have over 1,000 people attending, and these are offered on a pretty regular basis. The other thing we're finding is it's not just fitness. So as we surveyed our members, over half are commenting that they're now cooking at home, and that's something that they had not been doing before, was doing a lot of home cooked meals. So we evolved our curriculum, and we're doing instructions on the nutrition 101, the basics of cooking at home, and they're extremely popular. And I think it's just as members look to adjust to the new normal, having these live classes available has become extremely important. And I think the big thing that we see in the comments is it gives people that routine they need to make it through. And this gives them something to look forward to. These instructors are folks that they have come to know and appreciate, especially in live classes where we've got 300 or so. We will make an attempt to try and have that be two-way, where we will call out folks that we see logged in from Ohio or Pennsylvania, wherever it may be. But as we were doing that, we realized that even that wasn't enough, especially with these classes where the individuals had become a pretty tight-knit group. This was the group that they looked forward to seeing every Wednesday. So the other thing that we did was reach out to a lot of our fitness instructors who had been displaced, who were not able to teach their classes in the normal locations. And we started training them up on how to take their classes and teach them virtually. So while we had, alongside the national offerings that would have thousands of people, we also had instructors getting their group of 10, 12, 15 people on a Zoom session and teaching their classes. So the folks were able to stay connected to their friends and the people that they had come to see on a regular basis, maintaining that social connection. So, yeah, I think digital for us prior to COVID, it was an interesting thing. I think a nice add-on. What we've seen through COVID, though, is it can be a primary way of engaging people. If we look at folks who are engaging in silver sneakers, nearly a quarter of them are folks that had never engaged before. And so we do see digital and the ability to have these virtual classes as a way to onboard Medicare Advantage members and get them connected. And our hope is post-COVID, the folks that we've been able to engage digitally are folks that we can get reconnected into the communities where silver sneakers exists.
Terrific. Really, really fantastic. Just to follow up, as we're getting some questions coming in for I guess you could all come back online and we'll see your faces. It's just to ask a couple of questions. Give me some lines of what do you do with this going forward? I mean, do you quickly transition back to what you always used to do? Is there, are you going to want to do some of the same things that you've been doing? Because actually they kind of worked. And talk about that and talk about how prepared seniors are to handle this new technology. Are they afraid to come back? I mean, where do you see this, particularly with all those online, phone calls, all that kind of thing, fitting into the future? And I know we're not going back to normal for a while. So I think part of that is this isn't going to be next month. You're going to have to still be a lot of seniors at home for months ahead. So I think we're all anxious to declare it over, but it's not. So particularly in some communities across the country, new communities who are facing it anew. So maybe I'll even start there. Are you particularly where you either you operate nationally or where you realize that you have lessons that you learned where it was really bad and now you can pick it up even more quickly somewhere else, or reach out to networks you have to have them be able to respond more quickly. So start there with what you do to help the parts of the country that are now just experiencing real outbreaks, and if that's an issue, and how do you see some of this technology really informing your work going forward? Or some of these lessons learned about loneliness. I mean, these lessons learned here. So,
happy to start. I know June and Dr. Patel, you'll have some thoughts here as well. I think for us, one of the interesting things is we've asked the Medicare Advantage members about their willingness, and we've done a pretty steady job of staying engaged with them and getting their sentiment. As we've asked, how quickly would you return to the gym? Surprisingly, most of them say, look, as soon as I get the all clear, I'm back in the gym within a month. And I think 85% plus had commented that they would be back within a month. And I think it's easy to say that for them, and I think it really speaks to how much they're missing that community, the social aspect of it. One of the things that we're very intentional, though, is letting folks know that they don't have to rush it, that we have these digital options, we have ways for them to stay connected, and I do think that's going to persist. I think that as future events like this happen, hopefully on much smaller scales, that people will see digital as a way to bridge where you have times of disruption. And it could be inclement weather. You could have a series of blizzards, and having digital now play a role in keeping people in their routine when their in-community routine's been disrupted. I do think that this has been, probably one of the biggest benefits for us is seeing the way that the two play together, not necessarily one replacing the other.
Okay. June, you wanna?
Well, I love your reference to engagement. And I think there are opportunities in this crisis, including that people don't have to drive, they don't have to get up and get going. And so I'm interested if possibly you've expanded to new participants that maybe you wouldn't have had before. People have more time, and therefore they might have more interest, but I think I heard universally across the board that all of us are reaching out more assertively and more frequently and more persistently, because I think engagement actually is a tough thing anyway. And we all serve people who maybe should do some other things to advance their health, to cooperate with the good health care that they get, and they just don't do it. So how do you hook them? And so I think this is really giving us some opportunities to learn about that. And I was actually listening to Silver Sneakers thinking, oh, maybe we should talk, because maybe we could offer some of the other kinds of group activities that would supplement, because exercise is so powerful.
Yeah.
We focus on meds as number one, but the other number one is moving around. It's critical for their health.
That's great. Dr. Patel?
Yeah, it's really, thanks. It's really validating here how similar our approaches are. We were lucky to have Silver Sneakers right in our practices. And unfortunately, it was one of the first things that we, in-person Silver Sneakers classes, we stopped right away. And it's great to imagine what you guys are doing and make sure we're promoting it more actively than we may be already. I would say an angle to answer your question, Congresswoman, is that, things will never be the same, but they will change from where they are today, right? I think we're going to strive to strike the right balance, particularly for our seniors, particularly in primary care, particularly in our business of taking care of people's health. There's always going to be just a critical role of laying on of hands, of locking eyes, of spending time in a room together. We believe that relationships often are forged in those sorts of settings, in health crises, when people come to us at their most vulnerable moments and we're there for them in a very physical way. And we are able to do that today. So to be clear, we never closed down, and we were always able to keep patients cared for, especially if it meant keeping them out of the ER, managing them in the office. So we have, all the masks and PPE that we all read about in the papers. At the same time, boy, if all we do is a better job at taking care of people in the office, well, we're missing out on all those minutes and hours and evenings spent not in the office when our patients are really taking care of themselves. And so I'm really excited about the kick in the pants that we got, where we realized, oh my goodness, we thought we were doing a really good job of taking care of patients through the continuum between visits. And oh boy, we weren't, because we weren't delivering tablets to their homes with the physician's face already on video when they picked it up, because they don't know how to hit a power switch. And the demented patient's not going to do well with a tablet very often, right? There are certainly folks on the further end of dementia, and we weren't doing a good job of proactively reaching out to our patients and just asking them. We should know when they're going to run out of their medicines, right? Because we prescribed them in the first place, but we were still waiting for them to call us or call the pharmacy. We weren't really being proactive for all these really crucial things. And June, I take a lot of inspiration from what you're doing. We always thought of ourselves as asking folks about their whole life and their food insecurity and their emotional needs and their relationship struggles. But boy, when you are on a video with your patient, and I'm in my attic here, and you may see my daughter walking by watering the plants, and my patient is in her kitchen, and I can see her blender on the countertop behind her. There is a connection with each other and with family that we just weren't hitting when we were seeing each other in the office, as much as we appreciated that face-to-face. So I'm really looking forward to the best of both worlds, right? Deepening our in-person relationships safely as that opportunity expands, but also really taking advantage of all the real intimacy of a video call, right? And the frequency that phone calls offer, by the intimacy that comes through the frequency of those things without getting in the car, as some of you mentioned. So I'm an optimist. I'm looking forward to sort of striking the best balance, over the coming months.
I'm assuming that also, Dr. Patel, you really talked about this, but I think actually so did David and June, but just the fact that you mentioned this in the beginning, that Medicare Advantage, you didn't stop to think about, because you already had a capitated payment from them. You didn't have to stop to think of, wait a minute, I'm not going to get reimbursed for this. What should I do? Can I do that or not? How important was that? And the fact that you already had health coaches that had people's phone numbers and could start calling them, and it was just something you could do. How much you think? Because I think everyone, even the fee-for-service folks, had to step up and try and do that. But I felt like it still was it's a transformation for everyone. But it seems like the MA plans already had a system in place to build on, and infrastructure to build on. And it sounds like, obviously, June, you also did. You were already in the home. You're talking, so having that infrastructure, and of course, Silver Sneakers, you had to transition, but then build on that. I think it's great that you actually have added to it. But talk a little bit about how that really made a difference to your thinking about how you move forward during this whole COVID, and how that really mattered to you. And I don't know, maybe just the encouragement. We did hear from some providers who said they really matter to have those capitated payments coming in every month, and lists of patients, separated in that way. Talk about that for a moment, about how it really, you touched on it, but if you can, anything more you can add to that about how that will help you be able to do what you do going forward. And actually,
Sure.
supplemental benefits, because I know all of you actually rely on that too, to fill those other gaps that you weren't doing before.
Yeah, maybe I'll start. I think when we talk about payment models, it's very easy to approach the conversation and the question from sort of simple economics and thinking about incentives and thinking about the types of services that are reimbursed or can imagine new ones. But really, the one message I want to bring forward is that it's a mindset shift that, as a physician, I can tell you is really deeply fundamental. And I think we're so privileged and lucky to be able to work and play and learn in a single mindset of value-based care and not pivoting between patients. And my first job in healthcare as a high school student, I remember it was a pediatrician's office, and the chart had a sticker that said whether you're capitated or not, because I think the pediatricians had to, right there, right in the front of the manila folder, they needed to know, how do I approach this patient, because my payment model is different. We don't have to worry about that. So that allows us to do the harder work of having a mindset shift, right? And so what's an example of that? My colleague, Casey Henritz in Georgia, I don't know how many hours she spent sitting with their health coaches, conducting those first 10, 15 phone calls when we kicked off our phone call pilot. When we pivoted then to call our highest risk patients again and do some end-of-life care planning, advanced care planning, right? And talking about, hey, this is a tough topic, but we're in a pandemic and everyone's thinking about death. And if you're a senior, you're really worried. And let me open up the topic. And let me talk to you about your values, right? We did that thoughtfully, carefully, and we took people's time and we took them out of other traditionally revenue generating visits to say, hey, think about this and work on this, right? And try it out. And so that shift that, like, hey, my time is valuable, not just for the direct care I provide patient at a time, and sort of my efficiency isn't my only value. It's the outcomes of that end of life care, that values conversation, that theoretical value of if that patient ends up really sick, that they're going to be better equipped to have a conversation, or the family members will know what they wanted. That's really hard to quantify. So we were already in a mindset where we were able to sort of make trade-offs when it came to unquantifiable value for patients. And that's sort of part of what made some of these shifts easier. We were really excited when Medicare made some quick changes, and we're impressed by how quickly they made those changes, allowing video visits, for example, to generate some revenue for our colleagues, which is great. We need, they're out there taking care of people too, and also allowed risk adjustment to happen through those interactions, which is absolutely crucial. We take of sicker people and healthier people. Medicare needs to understand who we take care of and how sick they are, so we can get the appropriate funding. And at the same time, what the bleeding edge for us is figuring out how do we conduct those visits in order to document acuity and complexity in a world where our sickest patients can't get on the video and aren't willing to receive a tablet in the home, even though we offer that service and things like that. And so we're sort of solving those problems. So there's sort of all these advantages that value brought to us, Congresswoman, that you asked about, as well as these new challenges, right, that come from trying to adapt to operating an MA clinic, frankly, in a COVID era.
Okay, I don't know if I just lost myself on the Zoom or not, but hopefully not.
There. We see you.
All right, that's good. I realize that we do have a couple other questions, so let me just see if we can get a couple questions from the participants. Jonathan, can I turn to you and you'll help us out here?
Hi, Congresswoman. Yes, we've got a couple written questions. The first one is from Dwayne, and he wants to know about the impact of coronavirus in Q2 for Medicare Advantage carriers and supplemental coverage carriers, specifically in terms of new enrollments.
Oh, you mean like new enrollees, you mean, or whether it affected enrollment itself? What do you think you meant?
I'm just looking at the question here, and he says, sorry, he's popped up in the chat box, and he says, speaking of sales for new enrollments. Oh, like we have seen more new enrollment over that.
I think we don't know yet, actually. The enrollment numbers, are a little lag on that, so I don't think we've seen it, but I don't know if you have any impression about I guess, but it's a good question to ask either way. How did you deal with a new enrollee who you didn't have a lot of history with, who might have just signed up in February or something, and then suddenly, did you reach out to them, or
Some people that we care for.
people are looking at Medicare Advantage now, kind of like, why am I not joining that now? But
Some people we care for that are in Medicare fee-for-service are looking for a physician because under fee-for-service, a lot of those offices really shut down. They reduced their hours. They were not available. So you could see the dramatic advantage of having a PM and a managed care setting where the practice remained really fully available. So for us to be able to assist somebody in finding a practice that could really care for them, that might come to the home even as well, that would have all the flexibility that a Medicare Advantage practice can have, I think was really very powerful for consumers, but also I think for those practices that are working under that model. Wow, if this doesn't promote it for both sides, for patients and providers, I don't know what will. This should be the environment that really lifts up some of the dramatic advantages of Advantage.
David, you want to comment on that? I think that the question was also about access to brokers and agents and access to ship counselors was probably reduced there for a while. And I think there's some concern
They're
that
probably on the phone.
no, ship counselors, many of them are, well, they're volunteers. Obviously, they didn't have a site to go to. They were used to seeing people in person. Many of them over 65 themselves, so they weren't available. So that I think that's been a loss for the last couple of months. And for brokers and agents too, many of them go to people's homes and visit with them. Maybe some were prepared to do it online, some were not. So there may be a little transition here for people to just say, I didn't know what to do, so I didn't do anything, and they default into fee for service. So we'll see what happens with that. I think that was some of the, the advantages are sort of obvious to us, but if you don't know about it, if you don't really have someone who helps you through, at BMA, we're very well aware and actually concerned about how confusing it can be when you're a new enrollee. When you turn 65, you're sort of shocked yourself anyway. That takes a little getting over. And then you have to say, now I have to figure out Medicare. And it's a lot more complicated to actually make those choices than you think it is, and to really understand what your options are. So we actually think we have to make it a little bit easier on folks to, we'll do some work on that. Jonathan, you have another question?
Yes, we've got a question from Jason. Wants to know what companies are doing to address virtual care usage. And he adds that that there are reports that seniors are waiting 5 to 6 hours to be virtually seen by a provider.
Wow. Okay.
Oh my God, shame on us as we move to a virtual world that we recreate all of what we do in the office to patients in terms of digital waiting rooms and all these sorts of places. We have to do better, right? Our patients already deserve much better than what they were getting, and we certainly have an opportunity now to rebuild in a way that's more humane. So that is a real problem. We hear about that. I think one advantage that we offer to our patients is that we are a relationship-based. We are a primary care. We are your general practitioner. We are your doctor. We tell our patients that I tell them, I want to be your doctor for the rest of your life. And that's different than what you get from a off-the-shelf telemedicine solution, which is built often for convenience and transaction. 5-6 hour wait isn't convenient, so don't get me wrong, but it's built around transaction and convenience and maybe get your problem solved. It's not built around relationships or complexity or end-of-life decisions or things like that, right? So we meet our patients on video. So we've met already in person. And by the way, we're taking new patients. So we welcome, our broker partners and agents in the community will send us new patients because they hear from other patients that, hey, my Iora team called me. Thank you for connecting me with them. They called me out of the blue, right? And brokers love that because they're also 65 over many times. And so we try to leverage relationships in telemedicine, which I think then requires you to be on time. And it requires you to sort of introduce yourself and have a customer service face forward and bend over backwards sometimes for your patients in a way that is harder to do, I think, if you're operating in a more transactional environment where, I'm seeing patient after patient who I'll never see again, right? Like the way a traditional urgent care would.
Although I think there probably were, and maybe continue to be really issues, how do you make sure the person's there, they know how to do it, to get their, get their background information, all that kind of stuff. But they're just handling the technology and the infrastructure probably takes a little more work to set up than we thought it would. So
Absolutely. Yeah.
it's a push it too.
Our best health educators turns out to be, and behavior change enablers turns out to be really good at teaching people how to use tablets. It's a very similar skill set because it's a skill.
Yeah, exactly. Jonathan, do we have time for another question?
I think so. We're right at time, but we've still got over 50 folks on the line with us, so we could make this the last question if we wanted. But we've got a question from Carolyn, and she wanted to go back to the iPads, which the Congresswoman mentioned in regards to ChinMed, but I know that Dr. Patel also mentioned that these tablets are being provided by Iora Health, and wanted to know how that is, how payment and funding for that works.
Maybe I'll take that. Well, it depends on how you look at it. We all pay for them through taxes, and Medicare pays for them, but we do it through a value-based system, right? So rather than no one gets a bill for tablet, we appreciate that having tablets and being able to deliver them to our patients is going to bring value, and that's what they themselves are paying for when they sign up for a Medicare Advantage plan and put their tax dollars towards Medicare Advantage. And so we fund that ourselves, and we deliver those tablets to our members.
We actually asked CMS to allow that as a Medicare Advantage expense, a medical expense. There's some concerns from CMS that this could be, they could use those tablets for other purposes or that sort of thing. It'll be misused somehow. So we don't know if that continued, but it certainly was allowed. You could still do it through your rebate dollars, the savings that you get for, but it is, we hope some of that technology, the assistance of technology, just like the ability to pay for some remote monitoring, like you could buy, you can pay for some of that too, blood pressure, or something like that, that people don't say, oh, I don't want to pay for it, I can't. Theoretically, you could pay for that too. So it's one of those things that it depends on the value and the need and the assessment. But at this point, it's not broadly allowed in Medicare, but under Medicare Advantage, it is allowed for you to actually give someone a tablet for the purpose of medical interaction with your provider.
Let me be clear, because I know we were concerned about value and people want to make sure their dollars are being spent well. These are not Apple tablets because those are expensive. They're cheaper ones, and we deliver them. We take them back, and then we may deliver them again in a week when you need a follow up. So we find that it's actually more economical to deliver in recycle tablets than it is to leave them in the home where they may not work because the nephew will take over and install his apps, right? So we'd rather just keep control of it. We reset it, we clean it, and all that, and we do it in a way that we think is a net positive to the patient and to society.
Cost for the internet and all that kind of thing. So they don't necessarily work unless you actually have a system that's set up to do it. Just the device doesn't work by itself. I even know that. Correct. So yeah. So these are all sort of new questions anyway about interesting how you handle it. That makes a little more sense. So maybe with that, what I would say to people who have questions that we weren't able to answer is that we have them. If we can follow up, we'll try and do that. If, again, you want to be in touch with BMA, either with a question or a comment or some other important, wonderful work that you think is happening out there in the world as we but we rise to the occasion to meet these needs and hope that it really informs our learning for how we actually best serve Medicare Advantage beneficiaries in providing care for them going forward. But thank you to our panelists. Thank each of you very much, David and June and Neal, for taking time to share your experiences and look forward to what you continue to do with this. I think it's really pretty interesting things. And cooking classes is not what I thought that you do with as well in Tivity. That's a great idea. We're all cooking more at home, so a little bored myself of what I keep making for my husband. It's maybe time for us to branch out. But thank you so much again for your time and being allies of BMA, and to all the participants who are listening. Thank you too for choosing this particular Zoom webinar, and we'll keep doing it. So be well, take care, be safe.